my microphone. Welcome to our webinar today. It's co-sponsored by the Minnesota Gerontological Society, the Center on Aging, and MAGIC. MAGIC is the Minnesota Area Geriatric Education Center. Today's webinar is on the bipolar disorder in the older adult. I want to welcome you and thank you for participating in today's seminar. This webinar, I told you, is sponsored by three groups: the Minnesota Gerontological Society, the Center on Aging, and MAGIC. We are all broad-based organizations, and we have garnered attendees from every field and all over the state of Minnesota, and some from out of state. We've got over 175 people registered for today's seminar. I'm Pat Schomer. I'm the moderator for the seminar today. I am with the Minnesota Area Geriatric Education and Center of Aging at the University of Minnesota, and I'm also an MGS, or Minnesota Gerontological Society board member. More details and information about this webinar and other upcoming webinar can be found on MGS's website, www.mngero, so mngero.org. If you go to our MGS website and then to the webinar page, you'll find links to information that's discussed at today's webinar. There's also information on the website for our next webinar, which is on hoarding on Thursday, August 21st at noon. Also, I'll tell you, save the date for our annual MGS conference on Friday, April 24th of next year, 2015. We had a very exciting conference meeting this morning. A few logistics for today's webinar. The conference phone has been muted. If you have a question for the speaker, please feel free to type that question into the chat area at the bottom of your screen. If you have to leave the webinar early, just close your browser and hang up your phone. If you have other questions or concerns, please feel free to email us at MGS. After the webinar today, an evaluation survey will pop up. Please complete it immediately. It will only take you 3 or 4 minutes. You must complete this survey to receive continuing education credits. We're interested in learning what you liked and what you didn't like and what you think we can do better, and any future topic ideas. I can tell you that we value your input greatly. We are pleased to welcome today our presenter, Dr. Mary Butler. Mary is the Associate Director of the Minnesota Evidence-Based Practice Center at the University of Minnesota. She has extensive experience in all phases of technical briefs and systematic reviews. She's also led systematic review teams on varied topics, specialized in complex interventions and complex patients. Her interests include research synthesis methods and quality of care involving complex interventions in disability, chronic care, and behavioral medicine. I will tell you that despite this introduction, she is a very energetic, lively lady who I love working next to. But when I look at what she does for a living, I just want to take a snooze. So Mary, I'm glad that we're different people and that you have the talents and energy that you do. I really want to thank you today for presenting our webinar on this important and timely topic. And so I'll turn it to you, Mary.
Thank you, Pat. So I just want to underscore Pat's request out to folks. Please really do feel free to send in your questions. These types of presentations can be so much more interesting and rich when it's a conversation. I know it's hard to do when we've got as many people on the webinar as we do today, but we can still fit in questions and try and really explore this topic. And I also want to give a little disclaimer that when I gave the title to Pat and Tom and talked about what I was thinking about doing for the presentation, things have changed a little bit since then, and I was planning on giving a little bit more systematic review-y type of stuff with the idea of telling it along with the story of my own experience with my father, who is serving as our case study today. But things change, time moves on, and my father's story has progressed in even just these weeks. So we will still talk some about what we know, or what we don't know about treatment for bipolar for the older adults, but we're going to spend a little more time on really kind of trying to dig into not the answers, but the questions around working with kinds of complex patients. So, having said that, let's go ahead and meet my father. Our case study today is an 83-year-old white male, 6 feet tall when he was young and healthy, currently about 160 pounds. He was a retired Lutheran minister. He's a retired Navy Reserve chaplain. He was in the Coast Guard when he was in his early 20s. He is still married to his third wife. There are adult children on both sides. So just right there, just as a regular human, you can see that this is kind of an interesting character, shall we say. My father was diagnosed with bipolar disorder at age 50, but in his personal narrative, he places his likely first onset at age 17 when he was a young freshman heading off to college and experiencing his first episode during fall semester. He's diagnosed with bipolar disorder 2. Bipolar disorder 1 is the one that most people commonly think of, where you've got either major depression or acute mania. For bipolar 2, that acute mania is usually not there. Actually, that's the definition for bipolar disorder 2, that we don't have acute mania. We have hypomania. The types of behaviors that you see there are less around the potentials for delusional types of things and are more likely to occur in agitated and behavior, irritability behavior, things that fall into that type of category. My father also has possibly rapid cycling bipolar. The concept of rapid cycling isn't necessarily agreed upon within the field that studies and treats bipolar disorder, and whether it exists or not and how one would define it. Generally, it's usually thought of as switching between depression or hypomania or vice versa about 4 times within a 1-year period. The presence of both the rapid cycling and the early onset for the diagnosis are 2 risk factors that suggest that my father would have a perhaps more severe natural course for his bipolar disorder. So when an opportunity came up to dig into systematic review for treatment for bipolar disorder, I was, shall we say, pretty interested in checking into it and seeing what I knew versus what I thought I knew. But when it comes to the older adult, we don't know very much. It's very rare for older adults to be recruited specifically and very rare for them to be analyzed as a subgroup. That's not uncommon. I'm sure everybody's very familiar with that type of situation happening with most types of treatments, particularly drug treatments, and there are reasons why that happens. And so when there are efforts made to bring in our older adults into these types of studies, they usually look like these guys. People have in their mind the picture that's up in their triangle of the generally frailer looking folks, but the older adults that are beneath that sign, they were moving along at a pretty good clip when we took this picture. So the folks that we tend to see represented in the studies are of the healthier, usually on the younger side of older adult. So even though we may know some things, a few bits and pieces here and there for older adults, it's very rare that we really actually know about it for someone who's a complex patient and arguably frail, a frail older adult. So we're still relying, for the most part, on expert opinion for treatment for older adults, since there isn't much of an evidence base. Lithium is still first line for mood stabilizer, and the evidence we have is pretty much based on the full age range of adults. And that's considered really quite the gold standard. It doesn't always work for everybody, but there isn't much argument that it does have some efficacy. There are other valproate as a second line, but you can see here, even there, we start looking at a much more reduced evidence base. So even though it is an approved drug for bipolar, it's really based on not a very large patient population, and they're not generally elder, and it hasn't been analyzed for the elders yet. So it's already coming down to a much smaller base.
Okay, Mary, we've got a question from a person asking, what is the incidence of late onset bipolar 2?
That is that's a controversial one, because late onset, actually I was going to come to that later, so maybe we could set that aside for the moment, because I have some questions actually about that. So let's keep going for a moment. We do have a handful of FDA-approved treatments for mania and different anticonvulsants, atypical antipsychotics. There's a lot of things that are used off-label. There's nothing approved, well, I shouldn't say nothing. There are very few approved for depression. There's very poor evidence with regard to the effectiveness of antidepressants for bipolar, and there's some questioning in the literature about whether there's enough of a qualitative difference between bipolar depression and unipolar depression such that we cannot assume that they will be managed by the same types of treatments. There is a growing evidence base for behavioral therapies, cognitive behavioral training, family system therapy, and other related types of languages and taxonomies that are brought in to talk about behavioral therapies in general. But essentially what it comes down to is helping the patient develop their own self-regulation techniques to self-regulate emotion to the extent that it's under their trainable control, to help with the cognitions that can worsen their responses to situations, and also to try and come in and undo perhaps some of the relationship damage that can occur during some of the stronger episodes that may happen within the bipolar course of the disease. So it's it used to be sort of in the old days, kind of we just would give them a pill and then we thought everything was better. And thankfully, people have come to realize that residual damage needs to be addressed in order to give the bipolar patient the best opportunity to move forward in a functional way with healthy relationships.
Okay, Mary, Kathy asks if recreational therapy has been used as therapy with adults with bipolar disorder.
I believe so. I mean, in terms of practical, yes, but as far as studied, I haven't seen it yet. Not that specifically. But I wouldn't, there's no reason to think that there wouldn't be the possibility that a study would show different types of effects that you might be looking for, but we don't have an evidence base for it yet. The thing that happens is that when it comes to the behavioral therapies that tend to be used for bipolar disorder, in general are not necessarily the same as the types of behavioral interventions that might be used for a person with dementia. They're, and they require a patient who has the cognitive capacity to work on these things. But I'm getting ahead of myself, so let me step back for a second. For a cognitively healthy older adult, some of the biggest problems might be related to drug toxicity issues and potential polypharmacy issues. In this particular case, I'm going to come back to my father. My father has impaired renal function. That's not uncommon in older adults. He also happened to have been allergic to lithium. So he uses gabapentin as a mood stabilizer. So there's a couple problems with that. First off, gabapentin is cleared through the kidneys, and so that sets him up for potential toxicity issues, and we did experience that about 7 years ago. And when toxicity builds, the patient can be pushed into an induced mania, and it took quite a few weeks and a period on risperidone as an adjuvant to help get him back to a more stable maintenance phase. The other issue about gabapentin that people may or may not know is that the use of gabapentin for bipolar is off-label, and there actually was a $430 million lawsuit against the manufacturers for marketing gabapentin as an off-label use for bipolar disorder. So it was used fairly commonly for a period of time until that lawsuit stopped that behavior. We honestly really don't know. For my father, for gabapentin, there has not been any evidence developed. The evidence that's been looked at so far does not support the use of gabapentin for bipolar disorder. But my father believes it works. Whether it works for him because of some actual chemical mechanism, or whether it works for him because he thinks it works for him, and the psychiatrists that he was dealing with were happy to say, if you think it's working for you, we'll stay with it. I honestly cannot tell you. He also uses Lexapro for depression, which is also not necessarily one of the ones that's on the approved, FDA-approved list. And he also is currently on risperidone for behavioral issues that people believe were related to the bipolar disorder. And this happened within the last 8 months, and he continues on the risperidone. And at the time, it did improve his aggression and agitation, and they were his happy pills, and he was just a happy camper for quite a while. And I'll talk more about our thought process when dealing with that as we go on. But as a person with a severe mental illness, the issue of medical restraints becomes a little more gray area, and we have to deal with these questions one by one. But there isn't, again, necessarily a very strong evidence base for the use of risperidone for bipolar disorder. So back to the recreational therapy, there is some pretty good behavioral therapy evidence, but most of the types of things that are looked at usually require someone who has the cognitive capacity to really engage with the therapy or the training capacity, the short-term, long-term memory transfer, all of these kinds of things that would suggest that cognitive behavioral therapy or other behavioral approaches would have a chance to take hold. And again, I'm keeping these more towards not so much the in-the-moment therapies that are used to help improve the person's relaxation in that period, or to help keep an overall general good mood or what have you. But in terms of the types of therapies that are usually used to help maintain an episode-free bipolar condition. So when we keep in mind that these kind of require they're not passive, they're active, they're requiring an active stance on the part of the patient, it becomes a problem when you have some complex patients. So let's go back to my father and take a look at his brain health. Bipolar disorder has some of its own inherent concerns that we really don't understand with regard to the cognitive health of an older adult who has lived with bipolar. There is possibly evidence of brain volume loss. It tends to be with the chronicity of the bipolar, the long-term chronicity of the bipolar. There is suggestion in the evidence that first onset brain volume is not different from a healthy control. So it's not the fact of the diagnosis, but rather what happens over time. But we don't really know the driver of that. We really don't know any long-term effects of the psychotropic drugs. My father's been on psychotropic drugs for 30 years. We don't have studies that show us 30 years of effect. So it's what we would really need are the good longitudinal studies with the appropriate controls that help us understand what is contributing to what.
Mary?
So we're left, yeah?
We've got a question here from Kathleen. She says that she works with a few older adults that are currently taking Lamictal, Lamictal, for mood stabilization.
Lamotrigine.
Some feel that it works for them, she states, while others seem to become more anxious. And she's wondering what your thoughts are.
That is the trade name for one of the anticonvulsants that is FDA approved for the maintenance phase. So it's not there for specific mania, and it is not there for specific depression. I'm not a provider and I'm not a physician, so I don't feel particularly comfortable with speaking from that perspective. From a researcher's perspective and from the perspective of a person who has this in my life, what I can say, and even from some research that systematic reviews that we did on treatments for depression, we don't understand the etiologies usually of what's going on, and each individual is their own personal, unique, walking chemical factory. So when it comes right down to treatment, and this is where I'm at with my father, I follow essentially an experimental, I treat them like experiments. My father is a walking N-of-1 study. And everyone, when it comes to taking treatments, taking medications, doing behavioral therapies, we all have to attend to whether those treatments are working for ourselves as an individual, because most of our research is at a population base, and it has to be translated down to the individual, and each individual is a very complex system all on their own. So I would not be surprised at all to have a group of people in front of a provider or caregiver where for some people it works great and for others it doesn't. But that, again, I'm speaking on that as a researcher and my personal experience, not as a provider. So let's also take a look. My father has a few other things going on with his brain. He has idiopathic normal pressure hydrocephalus. This was diagnosed 7 or 8 years ago. And for those of you who may not be as familiar with it, that is essentially water on the brain. It's not, the water is not coming in under pressure, but it is accumulating in the ventricles of the brain, and that accumulation begins to put pressure on the brain tissue and can cause tissue damage. And in very severe cases, untreated, it can be lethal. For my father, we noted it because his gait started changing. He started becoming more confused. He was having increased incontinence, which had been there prior because of his prostate surgery. So kind of classic symptoms. He was seen by a neurologist, and they installed a shunt to drain the fluid. The shunt is on the right hemisphere. The first day he had surgery, he bounced out of it like it was day surgery, and he should have just been able to go home by the end of the night. Unfortunately, the shunt retracted from its original placement, and a week later he had to have a second surgery to reposition it. That time he did not bounce back, and within 24 hours was actually kind of sinking. He ended up spending three months in a long-term care rehabilitation facility, and that was where his gabapentin got started becoming toxic and had the induced mania. So he has this ongoing, not only from the hydrocephaly but from the brain surgery itself, that is on top of what we don't know about what bipolar disorder contributes to brain health. Then, 2 summers ago, my father took a fall down the stairs, smacked his head up against a concrete wall, and had a closed head TBI, had to be airlifted down to Hennepin County Medical. And as it would happen, it was the right side of his head that had the shunt that hit the wall. He had 2 small brain bleeds there. There was no surgery required. Who knew that a shunt for NPH would be prophylactic for a closed head TBI? And who knew that the gabapentin that he's on, rightly or wrongly, for his bipolar became prophylactic for the potential seizures that can occur after a closed head TBI of the severity that he had? So he's got kind of a messed up head, just to put it mildly. And as a matter of fact, within our own family, there are even some occasional jokes about if we really want him to be like a nice guy, we'll just smack him up on the right side of the head, because with each injury on the right side of his brain, he kind of got a little nicer for a while. But so we have a really complex situation here. So I'm going to start taking us into our current conundrum. What might we expect to see with someone like my father? What kinds of signs and symptoms might we be able to expect? So if you have bipolar 2, with trauma, and the bipolar 2 is acting up with occasional episodes, and for my father, you could expect to see depression. You could expect to see comorbid anxiety. You could expect to see hypomania with agitation and aggression. You could expect to see balance problems. His left leg was weak and continues to be weak after that TBI. There was documented cognitive impairment and a most definite loss of short-term memory and executive function, although we all wondered how much cognitive impairment might have been there prior to and contributing to that fall that he did take. You could expect to see the kind of paranoid delusions, not big delusions, but little delusions, That's very common with bipolar. You can expect to see the different types of memory problems where it's not that they're having a hard time remembering, but that their memories themselves can be very mixed up. And it shouldn't be surprising that this begins to look a lot like a list of things that folks would see with different forms of dementia. My father had the slums done, which, to remind folks, that's been validated on educated men in the VA. And that's a really good fit for my father. He was a very educated man. He was exceedingly proud of his IQ. He would share it whenever he had the opportunity while claiming he didn't care. It's not important to him. So this was a much better tool to use for someone like him, and even just a few months post TBI, when he was starting to come out of the brain fog of the brain injury itself, it was showing that he did definitely have mild cognitive impairment. He did definitely have some speech and language problems. He had some trouble with eating and was on and remains on a softer diet. The only thing on that dementia list that we haven't really seen with him is wandering or restlessness, but a very large portion of that dementia list is covered by the bipolar, especially bipolar plus his trauma. And so let me go back to the question about the late onset bipolar. I am speaking from a place of I am holding a very open mind because I haven't been convinced yet, one way or another, whether something called late onset bipolar exists. It could, or possibly it could be that there's such overlap with dementia that that functionally it really doesn't matter. It would only matter if the treatments would differ. And with the idea of late onset bipolar being so relatively new, I'm not even sure how much I would trust the incidence numbers, because I'm not sure I would trust yet how we're differentiating between what is thought of as late onset bipolar and dementia. And having seen recently also, or heard recently, some of the cognitive sciences is practically a hobby of mine. I find this stuff fascinating. And when I hear the neuroscientists referring to the brain as an ecology, I wonder. I wonder about the benefit of some of the labels that we put on these things, because the labels really have a tendency to focus attention on certain types of treatments. That can be very helpful, or it can be very detrimental. So, so again, let me just say I'm holding an open mind at this stage yet about what late onset bipolar may be and what that would suggest about how we should approach treatment for them. So I'm going to bring it down to the really grounded space of pre-TBI. My father and his spouse had enough ability to do compensatory behaviors, and they were definitely in collusion to create a sense of normalcy so that they stayed in their house. Post TBI, the house of cards came down because my father's wife also has some very major health issues such that she requires considerable care, and once he was no longer able to provide it to her, they had to consider some kind of long-term care facility. Her condition is progressive. For my father, we still, at that time we had no idea what was going to be progressive versus what was just the results of the trauma. So my father has moved from rehab for the TBI that he had. Then while we got his spouse settled into an assisted living facility that he was going to join her in. That one was a pod-based long-term care facility that was capable of providing hospice care, but it wasn't necessarily, it wasn't a nursing home. It was what his wife had thought would be an appropriate fit for her. Eventually there was a decision, though, to relocate them closer to her children. So they've moved from this pod-based care to an assisted living community. In this pod-based care, the care staff were within steps because it was a very small pod. You'd step literally out of the bedroom into the dining area. And if a person could take 15, 20 steps on their own, they could manage without a wheelchair. On the other hand, if the caregivers are really kind-hearted folks who are happy to get the person a cup of tea, I believe that my father and his wife actually ended up becoming less physically active because they had these really kind people ready to run up and down to get them whatever they wanted because they're just these very kind people. When they moved to the assisted living community with the very long hallways and such, both of their physical ability actually improved for a while. Let me check the time here. So here's my issue, and this is why things started changing a little bit, because we're now looking at the question of nursing care versus assisted living. For both my father and his spouse, the spouse has, again, this progressive condition. So we always knew that there would likely be a time where a transition to nursing care would be required. We didn't know about my father, but he actually appears to be progressing more quickly and has some very high care needs. And what I don't know is if they're reversible or not, because we've been through a few situations where they did. But our case study now is this 83-year-old white male presenting with severe incontinence, a lot of aggression and agitation, verbal outbursts that burn the ears off of most of the people that they're aimed at, excessive sleeping. He's very socially withdrawn. He's extremely wheelchair dependent, and seriously, the only things he does without assistance is he can brush his teeth, and when he's in the dining hall, he can feed himself. He does get himself to the dining hall without somebody pushing his wheelchair. I'll give him that, but it takes him about a half hour and a few short cat naps to get down there, and another half hour with a few short cat naps to get back to his apartment. So, what the heck's going on? Because this seemed to come on, but this could be completely perception, but it seemed to come on within about 6 weeks to 6 to 8 weeks. So what do we think? Could be bipolar disorder. It could be the NPH acting up again. It could be another progressive dementia form. We've ruled out so far sort of the obvious suspects of different types of infections and UTIs and pneumonia and what have you. So if we look at them one by one, bipolar disorder. Maybe it's, the first question on the with response to folks was maybe it's a major depressive episode. That's possible. Even though he's on the Lexapro, it's entirely possible. In this case, I feel it's pretty unlikely because this one comes with a behavior change I've never seen before. My father would call me, at least once a day, maybe 3 to 5 times a day. and I'm not getting any phone calls at all. So the level of withdrawal and apathy is really different than what we've experienced with him before. It could be that it's just the fact of the diagnosis of the bipolar disorder. There is some minimal evidence that suggests that people with bipolar disorder may have a higher risk for developing dementia than people with unipolar depression. But again, the research base that this is on is case control, cohort studies, in other words, observational research that's really hard to work with. It's hard to do well, although people try very hard, but it leaves always a considerable sense of uncertainty about how much we can be confident that those results will hold over time. The problem, too, is that the bipolar disorder doesn't really cover all of the symptoms that we listed there. We have folks who are happy to step up and say that they think his incontinence is a deliberate, a deliberate behavior on his part. There was deliberate intent or lack thereof. Or conversely, I could stand here and say lack of motivation has been a historical issue for him many times, and from the time he got his TBI on, he has been quite happy to actually not be responsible for much of anything, and he refers to me as his guardian. That is not a legal status that we have. I have his power of attorney. I am not his legal guardian, but he refers to me as that, and he's happy to let that be that way. So maybe it's the lack of motivation. We could look at a different antidepressant. We could try discontinuing the risperidone for the apathy, but that leaves the other behavioral issues really unaddressed. We've got possibly the normal pressure hydrocephalus that is known to be a cause for dementia, but the type of dementia that happens with this is usually more frontal lobe. It does have that apathy, the inertia, memory problems, incontinence, mobility problems. All of that would fit, but it leaves out all of the other types of aggressiveness that he has. But perhaps it's NPH plus bipolar. It's possible that the shunt is no longer working. It appeared to continue working after the TBI, but the evidence for shunts is that about 85% of the people will, if they're idiopathic normal pressure hydrocephaly, about 85% of the patients usually will respond positively to it. But over time, many of them may need revisions, and sometimes it's just not a good option. And I honestly don't know, and we have not even gone this far down the road yet, if it were to be that his NPH is worsening, what kind of a candidate he would be for a revision. Actually, in this case, it would probably be a replacement for the shunt. Possibly, maybe that might explain some things. There might be other undiagnosed forms of dementia that are progressive that we don't know about. There might be some history on his father's side, but the information on that side is I don't really have access to it, and his father died too young for any dementia to have developed, to have a sense of history on that side. And quite frankly, I have to ask the question of maybe it's just the accumulation of too much of everything, and his brain is doing the best that it can, but it is simply losing the ecology is no longer functioning very well. I don't know. So this was actually where I had the note on there that, you know, given with these kinds of difficulties of understanding all of this, I am still really curious about late onset bipolar. So now I'm going to get, as if I haven't been already, now I'm going to get a little bit more personal and just share a few thoughts that I've experienced as the person who's in the position of being the responsible party, and the kinds of things that I've thought about or have talked about with some of the other adult children on both sides. And I really want to preface this statement, any of these things, that I have the utmost respect for and intensely grateful to the providers at all of the facilities that my father's been at. I have without fail met some of the kindest people, some of the most, I mean, these are people who are dedicated, they're trained, they know their stuff, and they care. And I still worried, for example, would the staff rely too much on the bipolar label and not see what else was there? That's been a concern every time I've moved him to a new place. It is not an uncommon thing for there to be stigma from less informed times, and all of our own implicit biases that we may not even be fully conscious of. I know that I have to attend to where my implicit bias is. I tend to think that middle-aged women are just incredibly competent, and I have to look beyond middle-aged women to see my bias for them, as an example. So I have this fantasy of handing off to the county a parent who's always been intensely high maintenance, and if we can get him spent down to elder waiver status, I'm going to be able to just hand him off and have a sense of freedom that I haven't had in a long time. At the very same time, I can have fear about being forced to take this high maintenance person into my own home because nobody else will take them. These are not issues that are good things. You know, they're not based on anything real. They are the pure human responses that we have to situations that are challenging. I worry about having what I call the gardening philosophy of benign neglect. And I don't know if you've got other gardeners out there, where I tend to go with the plants that are a good fit for the environment that they're in, and if I can't find them a good environment, I'm not going to force them to live a miserable existence in a place that is not a good fit for them, where everything is a constant struggle. But having said that, I feel around me most of the time an often quiet but very pervasive social pressure to do absolutely everything you can to improve quality of life or longevity, or very often, you know, kind of both, just do them both. And I feel a very definite pervasive social pressure for a quote-unquote good death, whatever that might mean. And these aren't, you know, these are not necessarily really obvious and out there and in your face. They're very quiet, small stream that sort of runs underneath everything. So what it really comes down to is, as I work with this person, with the complexity that he has and embedded in the marriage that he has and the community that he's in, as we try to figure out what to do, the real question is, what's the treatment goal? And whose quality of life are we improving? Is it his? Is it his wife's? Because if his behavior definitely has, over many years, has impacted a lot of people around him. Is it the community overall? Do I try to find somehow a best balance for quality of life, taking into consideration the people in his life that are important? it's not necessarily immediately obvious to me which quality of life am I targeting to, to find the optimal improvement for it. So my last slide is I just wanted to say I'm, having said all of these things, I realize I haven't given any answers. There's very little evidence base to help but guide us. So there's nothing new here. These are, and this is actually a technical term, these are wicked problems that we're facing with providing care for the complex, frail, elderly people like my father. And, so the only thing that I mean, what I basically do every time I walk into a facility to take on an issue for him that needs to be addressed is to be as kind to one another as we all muddle our way through, because there aren't universal right answers, or very often no right answers at all. And so to the best extent that we all can, to practice self-compassion. So that's my story, and I'm sticking to it. Pat, do we have any questions?
Great job, Mary. Wonderful job. Do we have any questions out there? If you want to type them in right now, I'll give them to Mary. And while you're getting a chance to ask your questions, I will remind you that your survey for the evaluation will pop up automatically at the end of this webinar, and you must fill it out for CEUs. But even if you aren't interested in CEUs, we are interested in your feedback, and we take that very seriously. When I serve on committees for MGS, we always review all of our feedback very closely and try to meet your needs. You will also receive an evaluation survey in your email probably in about 1 day. Just fill out one survey or the other. To get CEUs, they are free to members, and they are $25 for non-members. We really encourage you, if you enjoy these seminars, to become a member. If you go to mngero.org, you can become a member. I believe the current price is $55. So for 2 webinars, you will get 10 webinars or 9 or 10 webinars for free. We do have another question here. Kirsten asks, Mary, if ECT was ever considered for your father.
No, he did not. That would be one brain trauma he has not had. His depressive episodes were not that severe, and usually ECT is for the refractive depression that is truly non-responsive to everything. And it's possible that in a way his rapid cycling may have been who knows, may have been somewhat protective of him on that he just didn't stay in a particular mood state for super long periods of time.
Okay, another person, Sarah, says, I hope that your dad has a health care directive and has discussed his goals and preferences for care. Have you considered a palliative care consult, Mary?
He does have a directive, and he has filled out the post. Palliative care is essentially what his choice has been, and this would be really when it becomes a question at the point of, for example, if it turns out that the normal pressure hydrocephalus is a driving cause, would we consider another intervention at this point in time? We did actually just finish a review on decision aids for advanced care planning. They'll be coming out in Annals in September, I think, Annals of Internal Medicine. And the problem now is that this wasn't a type of question he engaged in very strongly prior to his TBI. Post-TBI, we've been working with someone who's had some cognitive impairments, and I can see some changes in his, even how well he engages with things, cognitively engages with things. So that's why I struggle with that whole issue of the benign neglect gardening, because again, there is, you know, if he is not able to contribute to the decision and the decision rests with us, would we do that type of surgery knowing the frailty that he's going into it and not knowing the potential for benefit on the other side? I'm not sure. We're still kind of sleeping on that one a bit to see where family members fall out on it.
Okay, Mary, we've got two more questions here. Lori writes that she works with seniors as a service coordinator at an independent HUD housing site. She asks Mary if you could give specific behaviors of bipolar that she should be aware of.
Oh. Well, it depends on, it depends. So there's so many different types of, I mean, bipolar tends to be comorbid with anxiety. It tends to be comorbid with substance use. And so in addition to those types of things, the signs and symptoms of depression are you know, probably more commonly known. The signs and symptoms of mania or hypomania, you know, besides disturbed sleep and this sort of high pressure, rapid speech, inability to actually complete something because the attention just can't stay focused long enough. But the diagnosis of these things can be very challenging, especially if there is that comorbid substance use, because there can, I mean, separating out what's the drug versus what is the disorder can be very hard. Anger can often be very present, and depending on whether it's bipolar 1 or bipolar 2 or otherwise not specified. The one thing I will note particularly is that bipolar disorder tends to be diagnosed in whites. Schizophrenia tends to be diagnosed in African American, and there are some racial disparities with regard to how those diagnoses are approached.
Okay, Mary, we have got one final question here in this last minute. Does Minnesota have assisted living facilities and or SNFs, skilled nursing facilities, that have trained medical and social services staff on mental health issues? And she further asks, do you think that our elderly population deserve this type of facility, or is it even needed?
Wow. I almost feel like I should turn that over to you and Tom, because I don't know. As a matter of fact, I'm finding my journey through the facilities very enlightening, because I came into this with really not that much knowledge about them. When it comes to whether it would be useful, just as in like memory units, I think that we would all benefit from having facilities that are well trained in different types of behavioral issues, behavioral approaches to different types of issues. And when it comes to mental illnesses in the elderly, again, I get back to that issue that I don't know that the labels matter so much anymore as it is the functionality of it. And so again, we're doing another systematic review right now on behavioral interventions for dementia, so it's early days. I can't say anything about what findings might be, but as a general philosophy, I support more effort, as much effort as we can make available to meeting the residents where they are in their mental states.
Good. Well, thank you so much, Mary, for this wonderful webinar today. Thank you, everybody, for listening and joining and asking questions and thinking about this issue. I think in regards to this last question, the new ACL, the Administration on Community Living, which is the offshoot of the Older Americans Act, probably has something to say to Kathleen's last question that you just voiced, Kathleen, on assisted living facilities and SNFs and where people stand on mental health issues and facilities. Again, I remind you that our annual conference is the last Friday in April. That date is April 24th at the Earl Brown Center. Please mark your calendars. And our next webinar on hoarding is on Thursday, August 21st. We hope that you will join us. Remember to get your continuing education credits. You must fill out one of the evaluation surveys and give us information. We also wish that you would fill out those surveys even if you don't want continuing education credits so that we get your feedback. That's important to our planning. CEUs are $25 for non-members and free to our members of MGS. If you would like to join us, go to our website at mngero.org. So that's mngero.org to join